morning, dear esteemed colleagues. It's a great privilege to be here at 50 International Conference on Cancer Prevention and Research. I am Dr. Harun Demir. I am representing the Radiation Oncology Clinic at Konya City Hospital in Turkey. Today, I would like to share with you our clinical experience regarding stereotactic radiotherapy for brain metastasis from non-small cell lung cancer. In this presentation, we will delve into our 5-year data to evaluate clinical outcomes and, more importantly, the independent prognostic factors that shape our patient survival and recurrence patterns. I hope our real-world findings will provide valuable insight into the management of these challenging patients populations. The core aim of this retrospective analysis is to characterize the efficacy of SRT in managing intracranial disease in non-small cell lung cancer patients. Our primary objective is assessment clinical outcomes, evaluate local recurrence and distant brain recurrence following SRT. Identify prognostic factors, determine independent clinical and dosimetric predictors of local and distant failure. Survival metric calculate median overall survival and progression-free survival rates. Background, the clinical challenge. Brain metastasis occurs 20 to 40% of non-small cell lung cancer patients, often leading to significant morbidity and mortality. Stereotactic radiotherapy has replaced whole brain radiotherapy as a standard for limited metastases to minimize neurotoxicity. Despite technical precision, outcomes vary widely based on tumor diameter, dosage, and systemic disease control status. Effective management requires a deep understanding of which patients are higher risk of local failure versus distant intracranial dissemination. Brain metastases are a significant cause of morbidity in non-small cell lung cancer, particularly in adenocarcinoma subtypes. While stereotactic techniques are preferred for limited disease, whole brain radiotherapy remains a vital modality for extensive intracranial burden. Looking at methodology and study designs, a single-center retrospective analysis was conducted at Konya City Hospital between January 2022 and June 2025. 46 patients diagnosed with non-small cell lung cancer-derived brain metastases included our study. Median follow-up time is 9 months, range 2 to 52 months. Treatment response assessment was evaluated using response assessments in neuro-oncology criteria. Survival and recurrence probability were estimated using the Kaplan-Meier method. Univariate analysis, long-range tests to screen potential predictors, multivariate analysis, co-proportional hazard models to identify independent prognostic factors. Level of significance was accepted p less than 0.05. Here we see the basic demographics characteristics of our patients. The median age was 63. 80.4% of the patients were male and 65.2% had a high KPS score. Histologically, 54.3% were adenocarcinoma. The majority of patients maintain a high performance status at presentation, which is critical tolerating combined treatment. The cohort reflects a typical elderly non-small cell lung cancer population. Looking at disease control and pre-treatment characteristics, at the time of SRT initiation, controlled primary tumor rate 60.9%, uncontrolled extracranial disease was detected 28.3%. 3% of patients. Prime, prior to systemic therapy, most of our patients had no any systemic treatment prior SRT. 37% of patients took only chemotherapy, 2.2% took targeted therapy, 2.2% patients took only immunotherapy. Looking at metastatic presentation detail, symptoms and timing play a key role in urgency and prognosis. Symptomatic patients rate wide detected 60.9%. Synchronous brain metastasis rate 54.3%. Single lesion count 65%. Median diagnosis to SRT interval was 2 weeks. When we look anatomical localization of brain metastasis, we detected most of patients parietal lobe metastasis, 37%. Frontal lobe localization, 25%. Cerebellum localization, 15%. SRT planning and dosimetric parameters. Precise targeting was employed for all 46 patients. Median lesion diameter 22 mm, median PTV volume 9.2 cc, median radiation dose 24 J, median fraction number is 3. Confirmed index medians 1.2, homogeneity index 1.18, coverage was detected 96.8%, high target coverage detected. For initial treatment response rate, response assessments were conducted following SRT using standard random criteria for brain metastasis. Partial response mostly detected as 41.3%, complete response rate 30.4%, stable disease detected 70.4%, disease progression detected 10.9%. Combined objective response rate was 71.7%. Our median overall survival 10 months. 95% confidence interval 5.8 to 14.2 months. Follow-up range 2 to 52 months. At the analyzed time, we detect 69.8% of patients deceased. Here you can see the overall survival, local progression-free survival, and distant intracranial progression-free survival graphic of our patients after radiation therapy. Local recurrence was observed in 21.7% of the patients cohort. The median local progression-free survival was 25.9 months. During the study period, the median local progression-free survival was not reached. Despite the high biological aggressiveness of non-small cell lung cancer brain metastasis, SRT provided durable local control for the majority of the treated lesions. For patients experiencing local recurrence, various salvage modalities were utilized to regain intracranial control. The most common intervention performed in 40% of recurrence case. Whole brain radiotherapy utilized 30% of case as a salvage strategy. Repeat SRT focused radiation approach was applied in 10% of case. The choice of salvage therapy reflects a preference for surgical resection or comprehensive radiation when focal SRT control is lost. When we look multivariate analysis for local control, multivariate analysis identified a metastase diameter greater than 2 centimeters and a bed-10 less or equal 45 gray as an independent negative prognostic factor for local recurrence. Additional univariate analyses indicate that supratentorial localization and bed-10 greater than 45 gray had borderline association with improved local control. Patients with lesion exceed 2 cm had sevenfold higher risk of local failure. This aligned with global data suggesting that larger tumors harbor more hypoxic region and require higher biological dose for fractionated approach. PID-10 greater than 45 gray show a borderline trend toward better local control. Lower dose regime BID less or equal than 45 gray were significantly associated with recurrence. HR equal 5.4, emphasizing the need for dose escalation were clinically feasible. When we look at distant intracranial progression, distant brain recurrence remains a significant challenge post-SRT in these patients. Recurrence rate 52.2%, median DIPFS 10 months. Salvage modality for distant brain mass recurrence distributed equally among whole and focal brain techniques. 45.8% stereotactic radiotherapy and whole brain radiotherapy. Multivariate analysis for distant brain recurrence. Univariate analysis demonstrates a significant association between female seeing and shorter DIPFS, while a metastase count of 2 to 4 and low KPS showed borderline association with distant recurrence. In multivariate model, female sex and metastasis count greater than 2 were confirmed as an independent negative prognostic factor for DIPFS. Female sex was found to be independent prognostic for shorter DIPFS, while literature on gender-specific intracranial recurrence is emerging. This may relate to specific molecular subtypes often found in non-smoking females. Patients with 2 or more metastases had significantly higher risk of developing additional distant lesions compared to those with single lesion, such as a higher occult metastatic burden. In summary, lesion greater size than 2 cm and BID less or equal than 45 gray were associated with local country. While female gender and more than 2 lesions were significantly associated with distant brain control, the relationship between distant brain control and female gender is thought to be due to limited sample size. Our response rate was detected 71.7%, while median overall survival was 10 months. As a conclusion, SRT provides excellent intracranial control for non-small cell lung cancer brain metastases, particularly for smaller lesions. Tumor diameter is the most critical predictor of local failure. Larger lesions greater than 2 cm require aggressive dose regimens. The number of metastases at presentation serves as a sentinel for future distant intracranial dissemination. Combined focal SRT and systemic therapies, immunotherapy TKIs, should be prioritized for patients with multiple lesions to improve the IPFS. Our studies has some limitations. Retrospective nature and relatively small sample size, lack of comprehensive molecular profiling for all patients, potential selection bias in salvage treatment choice. For the next steps, prospectively evaluate the synergy between SRT and modern immunotherapy, investigate dose escalation strategy for larger brain metastases using fractionated stereotactic radiotherapy, validate the DIPFS gender association in larger multi-center cohort. For future research, strengthening the subject with multicenter studies and adding new molecular markers to the GPA score, as well as identify whole brain radiotherapy or SRT candidates using artificial intelligence algorithms are of great importance. We express our gratitude to radiation oncology staff, the multidisciplinary team, and most important, our patients and their families. Thank you for your time and for your attention. I would be happy to hear your comment. You can also reach out to me via the contact information provided.
Dr. Khalis Fatma. Presently, I'm working as additional professor in the Department of Radiation Oncology, SKIMS Srinagar, India. Today, I'm going to present a clinical case for IMRT in nasopharyngeal carcinoma, a definitive comparative analysis of long-term survival and toxicity from SKIMS. Nasopharynx is centrally located behind the nasal cavity, and it is surrounded by highly sensitive neurovascular structures like the optic nerves, the brain stem, then we have the salivary glands, then we have the spinal cord. That makes the surgical access notoriously difficult in this area. But tumors in the nasopharynx is highly radiosensitive, and that makes radiation therapy the definitive primary treatment. But because of the proximity to the critical organs, turns every stray gray of radiation into a potential lifelong hazard. Next. So there has been a fundamental shift from blunt coverage to the sculpted dose delivery. In the 2D era, two-dimensional conventional radiotherapy, it was based primarily on flat X-ray images and manual dose calculations, whereas in IMRT, intensity-modulated radiotherapy utilizes advanced software to modulate the non-uniform radiation beam intensities. In the 2D era, it was broad static rectangular fields, whereas in IMRT, it is 3D volumetric conformatory matching the exact irregular shape of the tumor. In the 2D CRT, maximum tumor coverage was there with contralateral damage to the adjacent tissues largely accepted as unavoidable, while as in IMRT, maximum tumor coverage, while there is we can actively spare the normal adjacent tissues and organs at risk. Next. So in this diagram, you can see in the 2D CRT, it delivers a massive parallel doses that pass straight through the healthy tissues, while as in IMRT divides the dose into thousands of modulated beamlets, sculpting the radiation around the critical organs to dramatically reduce the collateral toxicity. Next. So in SKIMS, we have done a study. It was a propensity matched cohort study, a highly balanced retrospective analysis of 60 patients with stage 2 to stage 4A locally advanced nasopharyngeal carcinoma was done from October 2016 to October 2020. We have taken 60 patients in the 2D CRT arm, and we have taken a total of 60 patients, 30 in the 2D CRT arm and 30 in the IMRT arm. As far as the demographics is concerned, 83 to 90% were males, and the median age of presentation was 54 in the 2DRT and 48 in the IMRT group. Regarding the disease stage, 100% had locally advanced disease stage 2 to stage 4A. And in the treatment paradigm, over 93% of the patients in both the arms received concurrent chemoradiotherapy alongside their primary radiation. Next. So the IMRT arm conclusively drives superior 3-year overall survival and the local control. Here, the overall survival was 85% in the IMRT group versus the 70% in the 2D CRT group. So there is an advantage of 15%. In the local relapse-free survival, it was 96% in the IMRT group versus 78% in the 2D CRT group. So there is an advantage of 18% in the IMRT group. The low regional relapse-free survival was 95% in the IMRT group versus 78% in the 2D RT. So there was an advantage of 17% in the IMRT group. The disease-free survival in the IMRT group was 95% versus 80% in the 2D CRT, and the progression-free survival was 90% in the IMRT group versus 84% in the 2D CRT group. Next. But the distant metastasis-free survival remains the shared frontier. While IMRT drastically reduces the rate of local and regional recurrence in the nasopharynx and the cervical nodes, it does not alter the rate of distant metastasis. So when we see the distant metastasis-free survival in the 2D CRT, it was 85%, while as in the IMRT, it is also 85%. So, because radiation is a local therapy, so the identical distant metastasis-free survival rates highlight that while IMRT optimizes localized anatomical control, addressing systemic micrometastasis relies heavily on the optimized concurrent and adjuvant chemotherapy regimens. Next. Regarding the toxicity, the incidence of severe grade 3 to grade 4 acute reactions during the treatment, we can see in the 2D CRT arm, the acute mucositis grade 3 to grade 4 was 83.3%, while as in the IMRT, there was no grade 3 to grade 4 radiation toxicity acute mucositis. While as in the skin reactions in the 2D CRT, 43.3% had grade 3 to grade 4 skin toxicity, while as it was only 3.3% in the IMRT group. So 2D CRT guarantees severe agonizing mucosal and cutaneous damage for the vast majority of the patients, while as IMRT almost entirely eliminates these grade 3 and grade 4 events. Next. Regarding the late radiation toxicity grade 3 and higher, in the 2D CRT, it was 100% incidence of late toxicities like xerostomia, while as in the IMRT group, it was 0%. Regarding trismus, in the 2D CRT, it was 63.3% incidence, while as in IMRT, it was 0%. Regarding otitis, 2D CRT had 26.7% incidence, while as in IMRT, it was 0. In the skin fibrosis late toxicities in the 2D CRT, it was 70%, while as IMRT group, it was 0%. So in the SKIMS cohort, 0 IMRT patients experienced late toxicity of grade 2 or higher across these key quality of life metrics. Next. So the golden quadrant is maximizing survival while minimizing the harm. So IMRT had 85% overall survival with 0% severe late toxicities, while as 2D CRT, the overall survival was 70% with 60 to 100% severe late toxicities. So IMRT breaks the historical compromise of radiation therapy. We no longer have to accept guaranteed permanent tissue damage in exchange for tumor control. Next. So to conclude, the definite standard of care is superior control. IMRT yields demonstrably better long-term overall survival and local relapse-free survival compared to the conventional 2D techniques. Preserve the humanity by sparing the salivary glands, auditory system, and jaw musculature. IMRT protects the patient's long-term quality of life. The paradigm shift the SKIMS Tertiary Care Institute study validates that whenever resources allow, 2D CRT must be retired. Intensity-modulated radiotherapy is the conclusive evidence-based standard for locally advanced nasopharyngeal carcinoma.
Hi everybody. Thank thanking you all for giving me this opportunity to present in front of you. I am Dr. Raghuveer Pedamallu, Associate Professor in Department of Urology from Nizam's Institute of Medical Sciences, Hyderabad, India. Today, I am going to present a topic on a systematic review on prevalence of FGFR3 genomic alterations in Asian bladder urothelial carcinoma patients. So, coming to the overall bladder cancer burden globally, in 2022, the overall bladder cancer burden is about 6,14,298 new cases, out of which China reports about 92,883 new cases, Japan 34,568 new cases, and India constitute about 22,548 new cases. Next, coming to the role of FGFR3 in bladder cancer. The FGFR3 encodes a fibroblastic growth factor receptor 3, a key driver in bladder urothelial carcinoma patients. The hotspot mutations activate FGFR3 signaling, promoting the tumor growth. The structural variants, especially FGFR3 TACC3 fusions, they carry a strong oncogenic potential. FGFR3 is the most frequently altered gene in Asian bladder cancer patients. Next, coming to the study objectives, we formulated 4 study objectives. The first one being to assess the FGFR3 prevalence, to determine how frequently FGFR3 genomic alterations occur in Asian bladder urothelial carcinoma patients across multiple datasets. Objective 2, to characterize the alteration types, that is, to describe the spectrum, point mutations, structural variants, fusions, and copy number changes, and identify the dominant hotspots. Objective 3, ethnic comparison, that is, to investigate whether FGFR3 alteration rates differ significantly between Asian and non-Asian patient groups. And objective 4 being informed targeted therapy. Evaluate the clinical relevance for FGFR3 directed therapies, that is FDA approved pan FGFR inhibitor erdafitinib. Next, coming to the methods, the data sources include large scale repositories from CBioportal, AACR3 Geni version 16, PubMed, that is from inception to July 2024. The inclusion criteria include bladder urothelial carcinoma or bladder cancer, and Asian, and genomic, and primary. 132 PubMed records are being identified, 11 genomic datasets are reviewed, duplicates are removed, 2 datasets are created from large-scale repositories, and 2 additional datasets are created from PubMed. And these datasets are analyzed for mutations, copy number variants, structural variants, fusions, which are assessed via CBioportal tools. This slide showing the 4 datasets used to assess the FGFR3 prevalence in Asian bladder urothelial carcinoma. Dataset 1 is derived from CBioportal, which shows 43 Asian patients of total 411 patients, which contributes about 10.5%. Dataset 2 is derived from a study by Clinton et al. In 2022, which shows 35 Asian patients out of total 1014 patients, which contribute about 3.5% of the total. 35 Asian patients of total 1114 patients, which contribute about 3.5% of the total. Dataset 3 is derived from AACR Geni version 16, which shows 104 Asian patients of total 2,845 patients, which contributes about 3.7%. Dataset 4 is derived from a study by Peak et al. In 2023, which shows 279 Asian patients out of total 8,728 patients, which contributes about 3.2% of the total. So the total patients across all the data sets are 12,998. The total Asian patients analyzed are 461. So next, coming to the key findings, the total Asian patients analyzed are 461, among which the average FGFR3 alteration rates in Asian patients are, they contribute about 18.4%. So the minimum alteration rate has been reported in data set 4, which contributes about 14.6%. The highest alteration rate has been reported in data set 1, which contributes about 44%. Next, coming to the FGFR3 alteration breakdown in Asian patients. The point mutations, which contributes about 14 to 28%, are the dominant mechanism seen across all the data sets. And the structural variants, fusions, they contribute about 2 to 14%, out of which FGFR3, TACC3 is the most common strong oncogenic driver. Next, coming to the copy number variants, which contributes about 0 to 9%. They usually occur along with the other events. This figure is showing a lollipop plot which shows the dominant hotspot S249C mutation. S249C is the most prevalent point mutation, which is located between ISET domain of FGFR3, which is classified as a driver missense mutation. The S249C creates a cysteine bridge, which constitutively activates the receptor. S249C is consistently the highest frequency hotspot seen across all the three data sets. This is the figure showing lollipop plot. So the most prevalent peak has been, that is S249C, is seen in all the three data sets. This slide shows the mutually exclusivity between FGFR3 and TP53, which is a recurring molecular pattern seen across all the Asian bladder cancer datasets. Usually, TP53 and FGFR3 are mutually exclusive, and this mutual exclusivity is seen in all the datasets, dataset 1, 2, and 3. So the dataset 1, this one is showing FGFR3 all, FGFR3 mutation, FGFR3 fusion, FGFR3 amplifications, homozygous deletions. This is 253. So the mutual exclusivity is seen in all the three datasets. So the mutual exclusivity suggests an independent oncogenic pathways informing which therapy to use in treatment. So the molecular profiling before treatment initiation is therefore essential in all the Asian bladder cancer patients. This slide shows prevalence of other genomic alterations along with FGFR3 in Asian patients. The other alterations being, along with FGFR3 and TP53, are CDKN2A, KDM6A, KMT2C, RB1, P1K3CA, ARID 1A. And this prevalence has been shown in all the 4 data sets. So the FGFR3, the prevalence in dataset 1 is 44%, dataset 2 is 23%, and dataset 3 is 16%, dataset 4 is 14.6%. Whereas P53 is dataset 1 is 23%, dataset 2 is 66%, dataset 3 is 56%, dataset 4 is 61%. And the other genes shows the following alterations, that is CDK into A in dataset 1 is 35%, dataset 2 is 14%, dataset 3 is 15%. And the other alterations has been shown in the table below. So this slide shows the comparison of the FGFR3 alteration among the different ethnic populations, that is Asian versus white, Asian versus African American, Asian versus European genomic ancestry. And these are all the data sets, 4 data sets, out of which data set 1 shows a statistically significant difference in FGFR3 alterations, that is between the Asian versus white and Asian versus African American patients. However, no statistically significant difference has been observed in the other data sets. Next, coming to the clinical implications. In 2019, FDA approved a pan-FGFR inhibitor, erdafitinib, that is trade name Balversa, which targets FGFR3 mutations and fusions, with an overall response rate of about 32.2% in clinical trials. However, it requires a TheraScreen FGFR RGQ RT-PCR companion diagnostic. Coming to the key conclusions, at least 14.6 to 18.4% of Asian bladder cancer patients, they carry FGFR3 alterations. S249C is the dominant hotspot, and FGFR3 TACC3 fusion is the most common oncogenic structural variant. FGFR3 and TP53, they define mutually exclusive subtypes, emphasizing the need for molecular profiling. So the ethnic differences in FGFR3 alteration rates observed in TCGA, that is with p-value of less than 0.05, in Asian versus white and African American. So routine molecular profiling should be integrated into clinical management before therapy for all the Asian bladder urothelial carcinoma patients. And I thank all my co-authors, that is Chandrasekhar Pedamallu and A. Ojesina, and from the Medical College of Wisconsin, etc. and IMSS. And I thank you all for giving me this opportunity to speak in front of you. And once again, thank you all.
Good morning, good afternoon, and good evening to everyone joining from around the world. Thank you to the organizers of the 5th International Webinar on Cancer Prevention and Research for having me here today. My name is Shruti Mahanti and I am from SCB Medical College and Hospital in India. Today I will be speaking on trends and disparities in liver cancer incidence by demographic factors in the United States. Liver cancer remains a significant public health challenge, and understanding how incidence patterns differ across demographic groups is key to improving prevention, early detection, and care. I am looking forward to sharing our findings and insights with you and to learning from the excellent research being presented throughout this webinar. Let's begin. Today, I will be presenting a study titled Trends and Disparities in Liver Cancer Incidence by Demographic Factors in the United States from 1999 to 2020. This study analyzes how liver cancer incidence has changed over more than 2 decades in the United States, focusing on differences across age groups, gender, race, and geography. The data used in this study comes from the CDC Wonder database, and the findings help us better understand which populations are most affected and why targeted prevention strategies are important. Liver cancer remains one of the deadliest cancers worldwide, and understanding these demographic patterns is essential for improving early detection, prevention, and healthcare planning. So, today I will walk you through the background, methodology, major findings, disparities observed, and the future implications of this research. To begin with, let us understand why liver cancer is considered a major public health concern. Liver cancer is currently the 5th most common cancer in the United States and one of the deadliest forms of cancer. Mortality rates have increased faster than almost any other major cancer type. The most common form is hepatocellular carcinoma, which accounts for nearly 90% of all primary liver cancer cases. One alarming fact is that death rates from liver cancer have more than doubled since 1980. Despite advancements in medicine, the 5-year survival rate remains only around 21.7%. This poor survival rate is largely because liver cancer is often diagnosed at an advanced stage when treatment options become limited. Several major risk factors contribute to liver cancer, including chronic hepatitis B and C infections, alcohol-related liver disease, obesity, diabetes, metabolic syndrome, and non-alcoholic steatohepatitis, also called NASH. Because of these rising risk factors, liver cancer incidence has steadily increased over the years, making this research highly relevant. Now moving on to the methodology of the study. This was a retrospective observational study using data from the CDC Wonder database, which is a public health database maintained by the Centers for Disease Control and Prevention in United States. The study analyzed liver cancer incidence from 1999 to 2020. Since the data was fully de-identified and publicly available, no ethical approval was required. The researchers selected cancer incidence statistics specifically related to liver cancer and analyzed trends according to age, gender, race, geographic distribution by state. The total population analyzed was over 7 billion person years, which makes this dataset extremely large and statistically reliable. The collected data was exported into Microsoft Excel and statistical analysis was performed using R software. Graphs and visualization were created using ggplot2. This methodology allowed the researchers to identify both temporal trends and demographic disparities in liver cancer incidence over a 22-year period. Let us now look at the major findings of the study. Between 1999 and 2020, there were approximately 513,000 reported cases of liver cancer in the United States. The overall crude incidence rate was 7.28 cases per 100,000 population. The incidence reached its peak in the year 2019, showing a clear upward trend over time. Another important statistic is that in 2022, the United States recorded more than 43,000 liver cancer cases, making it one of the countries with the highest liver cancer burden globally. These findings indicate that liver cancer incidence has steadily increased over the years and continues to remain a serious healthcare challenge. The increasing trend is likely linked to rising prevalence of obesity, diabetes, chronic viral hepatitis, and aging populations. This slide highlights one of the most important aspects of the study, demographic disparities. First, looking at age groups, the highest incidence rates were observed in individuals aged 75 years and older with a crude rate of 26.75 per 100,000. The 65 to 74 age group also had very high rates. This indicates that liver cancer risk increases significantly with age. Now, regarding gender, nearly 74% of all liver cancers cases occurred in men. Men had a crude incidence rate of 10.92 per 100,000 compared to only 3.74 in women. This means men are diagnosed at almost 3 times the rate of women. Possible reasons include higher alcohol consumption, greater exposure to smoking, hormonal influences such as androgens, increased iron stores in males. Next, race-based disparities. Asian and Pacific Islanders had the highest crude incidence rate at 10.12 per 100,000. White individuals accounted for the largest number of total cases. Black or African American populations also showed elevated incidence rates. The study also mentions that the median age at diagnosis is slightly younger in men than women. Overall, these findings clearly show that liver cancer does not affect all populations equally. This slide presents the geographic distribution of liver cancer across the United States. California recorded the highest total number of liver cancer cases, followed by Texas. North Dakota had the lowest number of reported cases. One important observation is that although absolute case numbers varied significantly between states, the crude incidence rate per 100,000 population remained relatively consistent. The higher burden in states like California and Texas may be related to large population size, higher prevalence of hepatitis infections, greater ethnic diversity, lifestyle-related risk factors. Geographic analysis is important because it helps public health authorities identify regions where screening and prevention programs may need to be strengthened. This slide shows how liver cancer incidence changed over time. Overall, the incidence steadily increased from 1999 and peaked around 2019. When broken down by age, individuals aged 55 to 64 showed a strong upward trend. Rates in the 45 to 54 age group began to decline after 2010. Regarding gender trends, incidence increased in both men and women. However, the rise in men was almost 3 times greater. Race-based trends showed how another important pattern, liver cancer incidence among white individuals increased exponentially over time. Other racial groups remained comparatively more stable. The slight decline observed around 2020 may have been influenced by disruptions caused by the COVID-19 pandemic, which affected cancer diagnosis and healthcare access globally. These temporal trends suggest that while some prevention efforts may be working in certain groups, the overall burden of liver cancer continues to rise. This slide explains the biological and social reasons behind the disparities observed. Starting with age, older adults experience greater genomic instability, telomere shortening, and genetic mutations, all of which increase susceptibility to liver cancer. Regarding sex differences, men generally have higher exposure to liver cancer risk factors such as alcohol use, smoking, and viral hepatitis. Hormonal factors, especially androgen activity, may also contribute. Now, discussing racial disparities, Asian and Pacific Islanders had the highest crude incidence rates, while alliance with global hepatocellular carcinoma trends, especially due to chronic hepatitis B prevalence in many Asian populations. The rapid increase in incidence among white population is thought to be driven by obesity, diabetes, non-alcoholic fatty liver disease, NASH, non-alcoholic steatohepatitis. This highlights how changing lifestyle patterns are becoming increasingly important contributors to liver cancer. Fortunately, many liver cancer risk factors are preventable. The study emphasizes several important prevention strategies. First, vaccination against hepatitis B is highly effective in reducing risk. Second, regular surveillance is essential for high-risk individuals, especially patients with cirrhosis, chronic hepatitis B, chronic hepatitis C. Current guidelines recommend abdominal ultrasound and alpha-fetoprotein testing every 6 months. If suspicious findings are detected, advanced imaging such as CT scans or MRIs should be performed. Lifestyle modifications are equally important. Avoiding smoking, limiting alcohol consumption, maintaining a healthy weight, preventing obesity and diabetes. The study strongly emphasizes that early detection through surveillance remains the most effective strategy for improving survival outcomes. To conclude, this study demonstrates that liver cancer incidence in the United States has risen significantly over the past 2 decades. The burden is highest among older adults, men, white individuals, Asian and Pacific Islander populations. The findings reveal clear demographic disparities, indicating that certain groups are disproportionately affected. The study also highlights the urgent need for better awareness programs, improved screening strategies, early diagnosis, targeted interventions for high-risk populations. Future research should focus on identifying emerging risk factors and understanding why certain populations continue to experience increasing incidence rates. Ultimately, reducing liver cancer burden will require a combination of public health education, preventive health care, lifestyle modification, and early detection strategies. Thank you everyone for listening.
I am BGP Thomas, the Chief Medical Physicist and Radiological Safety Officer, the Radiation Oncology Department of Caritas Hospital, which is from God's own country, Kerala, which is the southern part of Indian region. So I will be talking about HDR brachytherapy using customized surface mold and our institutional experience in angiosarcoma scalp. And first of all, I would like to express my sincere thanks to the organizing committee to give me this wonderful occasion. So I will be talking about the contents mainly, introduction, objectives, materials and methods, results, conclusion, and reference. So the angiosarcoma scalp ASS is a rare solid tumor with a high risk of local recurrence. Significant challenges for achieving adequate dose coverage while sparing underlying OIR, organ at risk. So HDR brachytherapy using customized surface molds offers a promising treatment option by delivering a highly conformal dose directly to the tumor-bearing surface. So the main objective is this study is to report the utility of high-dose rate brachytherapy as a boost treatment for a angiosarcoma scalp following external beam radiotherapy. And of course, we can use for another area like primary treatment of an squamous cell carcinoma scalp, SCCS. So material methods. So we have a 76-year-old patient with ASS underwent wide local excision and skin graft. In view of positive margin, she was planned for external beam radiotherapy of a dose of 50 gray in 25 fraction over 6 weeks. And after that, surface mold brachytherapy. So you can able to see the patient, a scalp of SS patient. And this is the customized gel bolus with the mold probes. A 0.5 centimeter thick gel bolus was customized and was used to cover the scar of about 10 centimeter diameter. And in order to cover this 10 centimeter, we need a 10 flexible interstitial applicators where sandwiched between these two gel bolus at a distance of 1 centimeter as the protocol of this brachytherapy. And the markings were made on patient's skull to ensure precise placement of the mold. And this mold, the next slide we can able to see. You can see this customized gel bolus with the mold probe placed on the scalp, and we are using a very tight, we are initially taking the marking of 4 corners and fixing very properly. And then a CT scan, Siemens somatome go up CT sim simulation was performed with a 1 mm slice thickness, followed by a reconstruction of the mold probes. The We are using the treatment planning system, which is the Eclipse version 17, was carried out for a prescribed dose of 13.5 gray in 3 fractions. So this is we termed as a boost in brachytherapy. It delivered as a BD. That means the daily 2 fraction and minimum a gap of 6 hours. Yeah. And this is the treatment delivery of this. This is the treatment was delivered with the gamma med plus EX HDR brachytherapy, which was given by the variant using iridium 182 radioactive source. So this is the patient position as a comfortable position. This is the guide wire which will be connected to the patient this applicator to the machine. So once everything completed, we will come out the treatment room and we will just switch on the machine. So automatically the radioactive source will come into the situated in the first probe, and the required time will be treated and it will be returned back and completing one by one, like 10 applicator. It will automatically, as per the treatment planning, the required time will be delivered. And the second case, we have a case with a 78-year-old patient was treatment with the customized wax bolus of 0.5 centimeter thickness with the 6 flexible interstitial implant tubes. So in these 2 cases, we are using a different type of customized. One is the gel bolus, and in this second case, it's the wax bolus, because you can able to see the one is in the central part of the scalp and another is the back side. So depends upon the suitable position, because the previous used gel bolus that we cannot be properly achieved in the back side. So we choose this kind of a wax bolus that is a very normal usage of the dental department, dental wax bolus. So the same thing we can use, and we are using for the interstitial brachytherapy. There is a tube is there, flexible implant tubes is there. So these tubes we can sandwich with this tube, 0.5 mm gap in between we are sandwiching. And the treatment delivery, you can able to the previous simulation is same machine and planning, everything same. But here we completely the treatment is used by the brachytherapy. So the dose of 50 gray in 10 fraction was planned and delivered as a similar BD. That means the daily 2 dose, 2 fraction. And you can able to see the how the patient is comfortably aligning, because since it is the back side, so he is in the prone position, and the remaining applicator, everything is same. So only we are changing the flexible, like customized wax bolus and the tube. So this is the 2 things only we are changing. And this is the planning part. If you come the three-dimensional view of the reconstructed applicator, after taking the CT in the treatment planning system, we are reconstructing similarly this 6 applicator and the wax bolus also you can able to see. And you can able to see the sagittal coronal view of the reconstructed applicator. You can perfectly reconstruct it as we are placed over the patient. The same thing we are reconstructing in the software also. So after that, the results is, after planning, we are able to achieve that is the protocol, 100% dose coverage to the 90% of the target volume successfully achieved. That is the D90 should greater than the prescription dose. So, and the hot. So we are in the radiation oncology, we are mainly looking at any cold spot, because which is anything under coverage or anything over coverage. So the hot, it is normally in this techniques, brachytherapy, normally we are checking the 150% of the prescription dose. So that should be less than 12 cc of a CTV. So that is V150 prescription dose less than 12 cc. So that should be the ideal protocol. So that we are achieving both, and our customized molds provides a high conformity to the scalp's anatomy, optimizing dose of the tumor while sparing surrounding normal tissue. So the normal tissue mainly only the brain tissue only, but we need to spare unwanted dose to the brain. And also we are able to deliver surface mold brachytherapy precisely with that most patient comfort. So that is the main primary concern. The patients are under periodic follow-up and severe toxicity has not been observed to date. And these are the some of the criteria we are protocol that is called dose volume histogram (DVH) of the SCS, that the squamous cell carcinoma, that's D90 50 gray. So that is we are merely achieving. And in this graph, it's showing DVH of angiosarcoma, that is D90 again 13.5 gray. So that's also we are very agreement with the protocol. And this will show the transverse view of mould reconstruction with the CTV getting 90% isolose. You can see this red line. So this is the isolose line which is passing over this area. So even though you can able to see there is a small air gap, but it is adequately completely matching or covering the entire area. So the conclusion, if you are coming, the customized surface mold ensure a proper coverage to the scalp than the available flap. So the available flap means automatic or the company supplied something is there, but it has a larger size and we cannot, this sideways, we cannot properly placing or re-simulating. It's very difficult. So we have a similar type of a customized one. It is very comfortable. And customized surface mold HD brachytherapy we can use it as a primary follow by EBRT, or as a like any other case also we can use as a boost treatment, and it will provide an excellent tumor control with a minimal toxicity, and it's a promising treatment modality for angiosarcoma and squamous cell carcinoma. And these are some reference of this angiosarcoma of the scalp, because it's a even we are treating started in 2003. This institute will start, and we all other interstitial, intracavitary, intraluminal, all type of therapy we are brachytherapy we are delivering. But and I am working in this institution since 2005, and in 20 years I have seen the first time we are this is done by just recently. Last year only we have completed, last year and this year. So I also seen only these two cases in the scalp region we are given. So that's why very rare, and it's challenging, but it is not much challenging, only because of we are able to produce this reproducibility. That is the only main challenges. Otherwise, we can very easily treat this one. So thank you.
Good afternoon, everyone. My name is Sezer Gökçe. I am a general surgeon at our Research and Education Hospital. Today I will be presenting our study titled Survival Outcomes and Clinicopathological Prognostic Factor in Gastric Cancer, Small Single Center Retrospective Cohort from Houston, Turkey. This work recently published in Kuala in January and represent our real-world experience with gastric adenocarcinoma and single tertiary center in one of the most research-limited regions of our country. Before I begin, I would like to declare that I have no conflict of interest. No financial support or funding received for study. The study was approved by the Institutional Ethics Committee of R. İbrahim Çeçen University. Given the retrospective design and the use of de-identified patient data, the recruitment of individual informant was viewed Ethics Committee. Background and rationale. Gastric cancer remains of the leading causes of the cancer-related mortality worldwide and continues to pose significant challenges, particularly research limiting settings. Contemporary guidelines strongly recommended multimodal treatment, meaning perioperative chemotherapy combined with surgery for patients with resectable disease. Key prognostic variables that guide clinical decision making included pathological tumor depth, nodal status, lymph node ratio, the presence of lymphovascular and peritoneal invasion, resection margin status, and perioperative systemic therapy. However, and this key point, real-world outcome data from Eastern Turkey are remarkable sparse. We simply do not know how our patients are doing compared to national and international benchmarks, and whether there are practice gaps and staging quality and perioperative treatment delivery. Reporting our local experience is therefore an important first step toward identifying these gaps and informing quality of improvement efforts. Study objectives. Primary objective was describe overall survival after curative intent gastrectomy for gastric adenocarcinoma, our centers. The secondary objective was to explore associations between overall survival and key clinicopathological factor, including surgery type, pathological T stage, lymph node ratio, lymphovascular and peritoneal invasion, resection margin status, and perioperative chemotherapy. I want to emphasize upfront that it was exploratory hypothesis generating study. Let me now describe our methods. This was a retrospective cohort study conducted in a single center tertiary hospital in Ağrı, Eastern Turkey. We included consecutive adults 18 years of age or older with pathological confirmed gastric adenocarcinoma who underwent the gastrectomy with curative intent between January and June. One important eligibility decision, we excluded patient we died with 30 days of surgery. The rationale was to focus our analysis on long-term oncological survival and avoid early postoperative deaths, distorting the cancer-specific outcome single. We explicitly report criteria to ensure the transparency and replicability. All data we were extracted from electronic medical records, including clinical demographic variables, pathological findings, and treatment details. The administrative censored date June. Statistic analysis. Third patients. Surgery, total gastrectomy, perioperative systemic therapy, median lymph nodes, R0 resection, eşe